Okay, good afternoon, everyone. Thank you for joining our masterclass today on 17th of May. I'm just going to introduce myself. My name is Sangeeta. I'm a clinical fellow at NHS England Transformation Directorate, and really pleased today to be hosting a joint ePrescribing masterclass with the MSO network. I am joined today by the lovely Emma Kirk, who is the MSO network lead, to co-chair today's masterclass. I will allow Emma to give a quick introduction of herself and just a few reflections on today's session. Emma, please.
Hi, thanks, Sangeeta. So hi, I'm Emma Kirk. I'm a medication safety officer on the Wirral at an acute hospital. I also am the MSO network lead, and I work for NHS Specialist Pharmacy Service, leading their medication safety. So I'm delighted that we've been able to join together to host another joint webinar following the success of the one from last year. I think it shows the importance of the relationship between colleagues that work within EPMA systems and the MSOs. And I know that we know that EPMA is not the panacea, but actually with all of the great work that we're doing, we are making medication safer for our patients. And, you know, out there are a number of people that have a joint role. So like Cassie, who is speaking shortly, she leads for EPR and medication safety in her organisation. And I think that just shows how interconnected we are as colleagues. So yeah, thanks for inviting us to join you all today.
Lovely. Thank you, Emma. Thank you for that. It was lovely to hear. Just for our listeners as well, as always, we have a great session for you today. Please do use the questions tab to ask any sort of questions you may want for our presenters today. We would encourage your participation because these sessions are geared to support you. So without further ado, please allow me to introduce our first speaker, Cassie Cordner. She's the lead pharmacist for EPR and medication safety at the Liverpool Heart and Chest Hospital NHS Foundation. She will be talking to us today about the closed loop experience. Without further ado, thank you, Cassie.
Thank you very much. So I'm Cassie. I'm the lead pharmacist at Liverpool Heart and Chest for our electronic prescribing system and medication safety. I'm going to be taking you through our closed loop medication administration process at Liverpool Heart and Chest. I'm going to discuss a little bit about what closed loop is and how we've seen some benefits realization in terms of patient safety. So what its impact has been within our trust. Next slide, please. So what is closed loop medication administration? So essentially, it's a digitally enhanced process using barcode scanning technology to confirm the right patient receives the right medication. So if we kind of look at the journey of a medication to a patient, the nurses during their medication round will select the patient on the electronic system and access their electronic prescription. They will then use the barcode scanner to scan the patient's wristband, and that will confirm the correct patient and any medications that are due to be given. The nurse will then take each box of medication and scan the barcode on those boxes to confirm the 5 rights of administration. So right patient, right time, right drug, right dose, and right route. If at any point any of those 5 rights are not correct, so for example, if the nurse selects the incorrect dose of a medication and scans the barcode, then this will flag up with a warning message and the nurse will be unable to proceed with administering that medication. So it's to try and prompt the nurse at that point to check that all the 5 rights are correct. Once all the 5 rights are confirmed, a match will be made and the nurse can then proceed to administer that medication to the patient and then move on to the next patient. Next slide, please. So looking at the journey of closed loop within Heart and Chest, just to give you a bit of background, we are a 200-bed single-site cardiothoracic specialist hospital. We've been live with Sunrise electronic patient record since 2013. And we were the first in the UK to implement closed loop administration using Sunrise, which is with Altera Digital Health, formerly known as Allscripts. So there's 3 phases to our closed loop administration. The first phase we rolled out in October 2021, and that was for all oral and nebulized medications. We then rolled out phase 2 in March this year, and that was essentially all other medications apart from controlled drugs and intravenous infusions. So this included stuff like insulins, medicated creams, eye drops, inhalers, patches, feeds. Phase 3 we are aiming for sometime next year, and that's going to look at adding in controlled drugs and IVs into the closed loop process. These obviously have slightly different ways that the nursing staff have a process and a workflow for on the ward. So at the moment, the system doesn't allow for that process to happen. So that's something that our Altera colleagues are looking into. So fingers crossed, we'll be looking at that next. Next slide, please. So how can closed loop administration improve patient safety? So if we look at the journey of a medication, you can see it's prescribed once, it's dispensed once, but it's administered multiple times. So there is greater potential for error to occur at the administration phase. Now, if you look at the prescription section, so when a doctor or a nursing colleague prescribes a medication, the pharmacy and nursing staff are there to act as a safety check to stop potential prescribing errors. Then if you look at the dispensing stage, pharmacists and nurses are there again to check the medications and stop any dispensing errors from reaching the patient. Now, historically, when it comes to the administration phase, there's no additional safety check before the medication reaches the patient. So there is the potential there for a drug error and for poor patient care. However, when you add in closed loop medication administration, that acts as a second check to prevent those administration errors and potentially improves the care that we're giving to the patient. Next slide, please. So we've actually been able to do some benefits realization looking at our closed loop process, and we've looked at data, our safety data with regards to administration incidents across the trust. So if you look at the chart here, the purple line shows our administration incidents that were reported to us in 2021 before closed loop was implemented. And the orange line shows those incidents reported in 2022, so once our closed loop was in place. And there's been a reduction in about 44% of administration errors, so we can see there has been a benefit. Now, I know looking at the chart there, the figures are quite low, but these are only those incidents which have been reported to us on our incident system. So we do know of other incidents that have been prevented, near misses, etc., that have not been reported. And we would expect that tracking across near misses, that we are likely to have prevented more errors. Next slide, please. So when we've done a detailed review into the incidents that were reported, when we looked at those in 2021, 23% of those could have been prevented by closed loop. Now, when we look at the pie chart on the right in 2022, 26%, so similar percentage, could have been prevented by closed loop. And that for us is because we still do not have controlled drugs and intravenous infusions available on our closed loop system. So there is still some work for us to do. Next slide, please. So when we look at the incidents which could have been prevented by closed loop and the types of incidents that could have been prevented, in 2021, we had 2 reports of incorrect insulin being administered, 3 for incorrect form, 6 for incorrect dose, 1 was the wrong patient, 3 the incorrect drug, and 1 incorrect time. And again, these are only those that are known and reported. In 2022, you can see that we still are having some incidents, but they have reduced. So no reports of incorrect insulin and none for wrong patient. Those that were reported were for controlled drugs and IV infusions. Next slide, please. So when we look at the implementation of the system and the kind of issues that we saw in the resolutions, there were several issues that we had which did result in disengagement from the staff. So that impacted our compliance. And also we saw this reflected in the figures being reported to us. So issues included scanners breaking or carts not working. And the resolution for this was to confirm a clear escalation process and to communicate that across the trust. We still do have some ongoing issues due to IT staffing levels, but it has much improved. Additionally, we did at the beginning in phase 1 have 2 separate processes for our medication administration, and staff were concerned about missing medications. So the way that the system works is that we have a work list manager, which is our not barcode scanning system, and then our barcode scanning system, and staff were kind of flicking in between the two. So we've now separated our administration charts. It's still all on one chart together, but it's separated into scannable items and non-scannable items. So it's much easier for staff to distinguish between the two, and that's actually prevented medications from being missed. Other issues that we have are barcodes not being available. So for example, if it's a patient's own medication in loose strips, or if they've brought in plain white boxes, etc. So we do have a process for this. So if there is no barcode available to scan, then you can use the no scan process, and pharmacy will resupply medications to that patient. We also have IT process in place to identify any barcodes we haven't got built in our system. And lastly, staff not following the correct process was a bit of a barrier and reverting back to non-closed loop administration. And this was often due to training issues and lack of understanding of the system. So multiple communications went out, we did lots of refresher training, and since then compliance has improved. Next slide, please. So looking at compliance, we have developed some reports to monitor this by looking at the percentage of staff that use the closed loop system. This is actually monitored weekly by the ward managers, and it's reported every month to our divisional boards and each quarter to our executive committee. And since this has been monitored, we've actually seen a significant improvement in compliance and less errors have been reported. Next slide, please. I just thought it might be useful to get some feedback from our nursing staff. So we did have a bit of a walk around, and some of our matrons were asking for feedback from staff on the ground. And some of the feedback included that the closed loop process made it feel safer for the nursing staff, minimizing errors, stopped some potential errors from reaching the patient, and it was a safer practice for both patients and staff. And we did have some feedback from patients and families and reports of patients feeling more confident. Next slide, please. So what's next in our closed loop journey? So as I've already mentioned, phase 3 will include all further medications to go live, so intravenous and controlled drugs, and that's because these are prepared away from the patient bedside, so a different process is required. And we're also going to look at a pharmacy dispensing interface to complete the closed loop medicines process. So this will be that the order for the medication goes directly from the prescribing system to our dispensing system. Next slide, please. And that's it. So any questions, please?
Thank you, Cassie. That was a really great presentation. Thanks for sharing your experience around closed loop implementation in your trust. We've got a couple of questions, if I may. So the first question that we've got is, what decision making informed your rollout of closed loop for the types of medication listed? And do you have smart pumps that are integrated with your EPMA system?
So firstly, no, we don't have the smart pumps integrated at the moment. That is on a project line somewhere. In terms of deciding which medications we went live with first and what phases to put them in, we essentially ran a report to see what was the greatest administration of medications, of which oral and nebulized came out top for us. And we decided to go with that first because we wanted to do 50% of our medications to begin with. We started this process because we were trying to achieve our HIM6 accreditation, and that required 50% of all medications to be administered via the closed loop process.
Thank you, Cassie. Quite a number of questions. The next one was, can you see this being potentially used as a second check for CDs or intravenous medicines instead of a second check by another nurse?
So this is something that we did pose to the nursing staff and got lots of shocked faces and terrified responses. So it is something that we are going to look at down the line. It won't completely remove the second check process because things like rate will still need to be evaluated. However, it is something that we are considering, but as we are looking at developing for controlled drugs and IVs. So I do think it is something that will be up for discussion, but I think that our nursing staff will feel quite uncomfortable about it.
Understandably. The next question is, has there been an increase in medicines costs as patients can't use their own medication?
So we haven't seen a significant difference. We have supplied slightly more, but we haven't drilled down into the exact figures. It's not been a massive issue because we have quite short stay patients here because of the nature of our patients. So it's not caused us too many problems. The biggest problem is when somebody comes in on something that we don't normally stock within our system, and they just have to use it as the no scan process until we're able to get stock of that medication in. So that would be the biggest barrier so far.
Thank you, Cassie. There was another question about whether closed loop has put any extra workload on pharmacy staff, or has it improved the dispensing processes, in your opinion?
So I think to begin with, it has increased slightly as we now have to overlabel some of our medications with a barcode. So any of our medications that have outer packaging with the barcode on needs to have a barcode stuck onto the inner packaging, if you like. So things like inhalers, any liquid medications that in bottles which have an outer box with the barcode on, eye drops, insulins, etc. They all have to have a pharmacy label with the barcode stuck onto that medication so that it can be scanned. So that has been a bit of a battle to begin with. Now we've got processes in place, it has helped. However, because of this, the system and the impact on the dispensary, we have obtained new staff. So part of the funding for the project was for some additional pharmacy staff to help support this, not just implementation, but our business as usual processes.
Thank you, Cassie. Just a couple more questions, if I may. There's a question about if closed loop allows nurses to modify doses. For example, are they allowed to give 2 1.25 milligram bisoprolol tablets for a 2.5 milligram dose to avoid missing the 2.5 if that's not available?
So this is where I'm going to confuse everybody, unfortunately. So our system, our drug dictionary, if you like, on our electronic prescribing system is built in two parts, if you like. So we have most of our medications are prescribed at a virtual medicinal product level. So that means it would be amlodipine 5 milligram tablets. So most of our prescriptions are as that. So that means that the nurse has to scan amlodipine 5 milligram tablets. So if the nurse wanted to give if a patient a 10 milligram dose but only had 5 milligram tablets, they would be unable to do that. However, some of our medications we have prescribed at a different level, which is essentially just the drug level. So just bisoprolol tablets without any strength. And that means that they can scan whatever strength of tablet they want to. It just has to make up the correct dose. So we have, I think, 15 medications that are built at that level, and they're the medications that we chop and change the doses frequently. Things like bisoprolol, ramipril, frusemide, etc. All of our other medications are built at the higher level that includes the strength and the form, etc. It is a little bit complex, the decision making behind that, because we're also looking forward to when we interface with our pharmacy dispensing system, and that will have a major impact on that going forward as well. However, most of the medications that are at the lower level, so just the drug level, they are stock on the wards. So in terms of dispensing in pharmacy, it hopefully won't have as big as impact on our team. I think that is as best as I can explain, but if anybody has any more questions or if I can explain a bit better, please let me know.
I think that was really clear, Cassie. Thank you very much for that. There's a question a little bit about implementation. There's a question about the time and analysis for administration. Did you do any sort of research in terms of the standard process versus the closed loop process? Did you get a feel of the time burden to the nursing staff in terms of analysis of these two processes?
Yes, we did. So we did full process mapping to begin with, and we also, one of our project leads did a timing study. So they did a study on how long it takes to do a medication round, you know, each patient or a bay of patients, etc. And they did it on various different wards, so surgical and medical. And critical care, and then the audit was redone after we'd implemented closed loop, and we actually found that it was faster doing the medicines round after closed loop had been implemented. Now, I would like to say that it's because the system's so quick and slick. However, I must say, I think a big part of this was to do with the fact that we reviewed the stocks on the ward and where we stored things and how nurses could access things. So we actually, for a lot of our critical care wards and coronary care unit, our patients are in individual rooms, etc. And it was going to be very difficult for nursing staff to fight over boxes of medication to scan them. So we actually have small little stock cupboards in each of those areas now with the top 10 drugs that they would use, so they're not having to go backwards and forwards all the time and borrow from other patients, etc. So I think a lot of the timing is actually down to that now.
Thank you, Cassie. Just the last question before we move on to the next segment. There's quite a number of questions. So one of them is, how long after EPME implementation did you introduce closed loop at your trust?
So about 8 years. Closed loop wasn't really a thing when we went live with our electronic system. So there was a lot of time for our staff to be used to the electronic process before we implemented closed loop. Yeah, so I think they were already used to kind of part of the process, if you like, before we implemented this.
Thank you very much, Cassie. That was a fantastic example of how digital innovation in the form of closed loop has supported with minimizing human error. I will hand over to Emma for the next section of our webinar. Thank you.
Yeah, and thanks, Cassie. I think that was really, really interesting, and there are still loads of questions coming through, so we will send them to you to answer, and then put the answers up on the future site. So if you have got a question, don't worry, we will see if Cassie can answer it for you. So it gives me great pleasure to introduce our next presenter, who's showcasing a great safety solution where the benefits are really seen across the system. So we know one of the hotspots for medication errors are at that transfer of care stage, various stages. And also I think many of us would say that opioids were pretty high on our list of worries. This solution really addresses both of those. And I really hope that the informatics team from my organisation are listening, because this really is something where I'd love to be able to replicate in our system. So I'm going to hand you over now to Suzanne from the Dudley group. Thanks, Suzanne.
Thank you very much for that introduction, Emma, and I'm really pleased to be presenting the Masterclass online today. Next slide, please. So before I discuss our safety solutions, I think it would be really helpful to share a bit of background about my organisation, the Dudley Group. So geographically, Dudley is located in the West Midlands. We're in the heart of the Black Country and part of the Black Country ICB. We provide both acute-based care and also community nursing services, and we serve a population of over 300,000 people. As part of our EPMA journey, we went live on the 12th of August 2020 with the Sunrise EPMA system, so the same system as Cassie has previously described as being in use in her organisation. And we went live between the first two waves of the COVID-19 pandemic, and I'm pleased to say that we've never looked back. Next slide, please. So the safety solutions that I'm going to discuss with you today all relate to the design and implementation of a community end-of-life drug authorisation form, which is also known as a CEDA form. And the purpose of the form is to enable our community nursing teams to administer injectable medicines either as a subcut stat dose or via a syringe pump for patients who are discharged from hospital and who are likely to need these medications for symptom control in the last weeks or days of their life. So we launched our electronic CEDA form earlier this year, and this digital solution means that if an anticipatory medicine or a syringe driver is prescribed for a patient on discharge, a CEDA form will automatically be Next slide, please. So why was a digital solution needed? Firstly, prior to the launch of the electronic CEDA form, the discharge letter was used as an authorisation for a community nurse to administer medication. It was only valid for 96 hours, and at that point, the patient's GP needed to be contacted to write an authorisation. And I'm sure those of you that are on the call today as healthcare professionals and digital experts will know that improving the transfer of information across health and care settings can help to reduce medication errors and improve patient safety. The electronic CEDA form has a number of advantages versus a paper system, including reduced opportunity for prescribing and transcribing errors when writing discharge letters and authorisations, preventing delays to medication administration whilst waiting for an authorisation, and also clearer and more detailed communication across the interface. And equally important as the direct benefits is the potential time it saves, enabling nurses and prescribers in both the acute and community settings to spend more time providing direct patient care. Next slide, please. This slide shows our CEDA form development process. It all started with a small MDT group and the design of a process map of our EPMA pathways for prescribing and administering end-of-life medications for inpatients, and it grew from there. We established a stakeholder working group and we worked closely together on the design and configuration of the end product. So I'm now going to describe some of the digital solutions that we've implemented in our EPMA system to reduce errors and improve patient safety. Next slide, please. This slide shows our end-of-life care gold standard framework, or the GSF document, and this is completed by the clinician for all patients that require end-of-life care. When a GSF code is selected on the document, the patient's GSF status is then visible for all system users on the inpatient dashboard, and you can see it in this slide highlighted with the grey arrow. Next slide, please. When a patient requires anticipatory medicines for symptom control, the prescriber enters the order, and at all times they can see the patient demographic details, including allergy status, clearly on their screen. An order set was designed to reflect the Trust end-of-life care guidelines and to make the prescribing process more efficient. When this order set or a syringe driver order set is prescribed, a warning message pops up each time, and this raises awareness of our Trust guidelines and also informs prescribers about how to contact the specialist palliative care team for advice 24 hours a day. Next slide, please. So this slide shows our order sets, and it summarises the initial medications and doses for symptom management in patients with different renal functions to support clear and unambiguous prescribing. Both drug choice and doses can be modified and adapted because, as we all know, it's really important that these medicines are adjusted for individual patient needs. Any medications must be ticked in order to be prescribed, and you can see this in the example shown with the levomepromazine injection. Next slide, please. So once the medications have been prescribed, they appear on the EPMA in two formats: the Orders tab, shown on the left, and the Worklist Manager, shown on the right, which is the drug administration record for our nursing staff. And as you can see from the image on the right, although the system design prevents prescribing of drugs by multiple routes in one prescription, as you might have traditionally seen on a paper chart, for example, morphine 5 mg PO/IV/subcuts, it is still important to take care and read the Worklist Manager carefully, as both the subcut PRN and the oral formulations appear in a similar format on the Worklist Manager. Next slide, please. As I previously mentioned, an order set was also designed to support the safer prescribing of medicines in a McKinley T34 syringe driver pump. Next slide, please. This order set incorporates a number of features to enable more efficient prescribing practice and reduce the opportunity for error. The prescriber simply types each medication required in the syringe pump into the medication to add box, which is shown as box 15 on this slide. And they select from a drop-down box of medications that were pre-agreed by our stakeholder group as suitable for use in a syringe pump. The prescriber is also prompted to select an appropriate drug concentration. So, for example, morphine 10 mg in 1 ml or morphine 30 mg in a ml, and also to type the correct dose. The selection of a base solution and the correct syringe size are both mandatory, but drop-down menus have been supplied to support safe prescribing choices. The duration of the infusion is automatically configured, and it will populate the duration of the infusion to last for 24 hours. Another benefit of the system is that prescribers can add special instructions into the box that's shown on this slide as box 19, and these are visible to the nursing staff when they both prepare and administer the medication. Next slide, please. On the right-hand side of this slide, you can see how the syringe pump order appears for nursing staff and is highlighted blue to indicate that this is a continuous infusion. Next slide, please. All these safety solutions come together on the CEDAR form when the prescriber adds anticipatory medicines or a syringe driver to a discharge prescription. Our CEDAR form has got two sections. Section 1 is for the PRN drugs, and Section 2 is for the syringe drivers, and you can see Section 1 on the slide in front of you. The forms also incorporate some additional safety features to support safe transfer of care. Firstly, you can see the patient demographics print on each page, as well as the patient's GP and the GP address. And secondly, any controlled drug patches that are prescribed on discharge are automatically populated on the form, so that this information can be used to assist decision-making in primary care about dose adjustments. You can also see that there's a table of discharge medications on the CEDAR form, and this is created using configuration rules, so that only the intended drugs by the intended route populate on the form. And finally, the CEDAR form must be clinically checked by a pharmacist before discharge. One of the benefits of our electronic CEDAR form is that as part of our stakeholder working group, we made a local decision to extend the validity of our electronic CEDAR form to 3 months, as opposed to the initial 96-hour period that the paper format was valid for. Next slide, please. This slide shows Section 2 of the form, and it only includes medications prescribed for use in a McKinley T34 syringe driver for administration via continuous subcut infusion. As you can see, each syringe driver is labelled and each drug is listed with the starting dose over 24 hours, base solution, volume and infusion duration. In this example, you can see that the patient's only prescribed one syringe driver. However, multiple pumps can be prescribed. The form also includes a summary of some safe practice points and contact details for our palliative care team. A key feature of our CEDA form is that it will only be displayed and printed with the discharge letter when a patient is prescribed discharge medications that meet our configuration rules for end-of-life care medications. If there's no medications to show, then the CEDA form doesn't display on the reports. Next slide, please. A really important part of this project was to ensure that the CEDA process could also be replicated by GPs in the community who don't have access to our ePMA system. So the paper form was designed mirroring the format of the eCEDA and has now been uploaded to the GP prescribing system, EMIS. Next slide, please. So I'm now going to move on and discuss some pre and post go live checks. So before we launched our CEDA form, the stakeholder team devised some realistic case-based scenarios and involved both acute and community nursing staff, prescribers, GPs and pharmacists to work through these scenarios and feedback any issues that they identified. Our clinical safety team approved the final product, and we also launched with an e-learning package, quick reference guides and trust-wide comms. The IT team were also on hand during the pre and post go live period, and really beneficially they did floor walks to support our nursing staff and prescribers on the shop floor. So during our pre and post go live period, we had regular checkpoint calls with our stakeholder group to ensure that the product was launched successfully and safety, and we've got ongoing monitoring in place through our IT help desk and also our incident reporting system. Next slide, please. I'd like to close the presentation today by sharing my top tips for project success that you can apply to your own ePMA projects. So firstly, identify your key stakeholders at the start of the project and keep engagement going. We use 30-minute meetings and a combination of Teams chats, but I would really recommend that you agree your regular touchpoint calls with your key stakeholders at the start of the project. Secondly, consider the entire medicines use process so that you capture the whole patient journey from administration to discharge and to transfer. Thirdly, explore and agree a list of key design elements, your patient safety must-dos, and keep focused on these when you're making your decisions. And finally, be aware of the potential risks and the pitfalls of the process that you're designing. As we well know, ePMA users don't use the system as we might expect them to, and our patient pathways are often complex. So do take the opportunity to try out these scenarios during your product development and UAT. So our goal was to achieve seamless transition of end-of-life care between the hospital and the community setting. And I hope that you've enjoyed listening to the presentation about how we've enhanced and improved patient safety through our CEDA ePMA journey. Thank you for listening.
Thank you so much, Suzanne, for sharing that with us. And thank you for those top tips, which I think we can replicate in any projects that we take. Within the project, did you encounter any challenges, and if so, how did you overcome them?
Thanks, Emma. A really good question. And I think the first challenge was establishing the right stakeholder group. It's really important that we had involvement with our GP colleagues at the start of this process so that we can consider both the acute sector and the community care needs. But more specifically, a couple of issues that we identified in our UAT testing were that in the community, our nursing staff were used to seeing the prescriber GMC number or the prescriber registration number on the paper CEDA form, and in the acute sector we were very used to seeing a digital signature and accepting that as our sort of standard of care or accepted standard of practice. But feedback from the UAT established that our community colleagues would really like to see this on the electronic CEDA form. And unfortunately, this wasn't built into all our prescriber processes within the ePMA, so it could be auto-populated when the CEDA form was generated. So we quickly designed a manual box that the prescriber can type in their registration details when the CEDA form is completed. So that sort of designed out that problem. But ideally, had we known that from the start, we would have made sure that all prescribers had got a registration number that was associated with their profile and would auto-populate on the form. And secondly, it kind of links into what Cassie was saying with her experience at her organisation about the way that the drugs are configured within an ePMA system. And we have got a different configuration to the one that Cassie's describing, where we have where they have drug strength within their profile that's visible on their work list manager. We don't have drug strength highlighted in our ePMA worklist manager. The prescribers prescribe a single dose. So, for example, if they're prescribing morphine, traditionally they would have prescribed morphine 10 milligram, and that would have pulled through onto the CEDA form. But what we identified was that we needed to have a drug strength in brackets on the drugs that were used for end-of-life care. So these would then pull through onto the CEDA form so that our clinical staff could check for things like compatibility and ensure that we could get the final volume in the syringe, because unfortunately we did identify an error where not the compatibility, where the concentration of the medicine that had been supplied meant that you couldn't fit the total volume in the syringe. And we felt that we could have designed that out with our CEDA form process if we'd identified that earlier on in our sort of CEDA process.
And then there's a couple of questions in the chat here about the wet signature. So I presume this CEDA form is not what you then dispense from. So there's another system for that, is there?
Yeah, that's a really interesting question, actually, and I didn't want to go into too much detail because I thought people might ask this. So this is a community drug authorization form, so it's not a prescription. So we've got our inpatient ePMA system, and then we've got this document, which is the CEDA form, which is an authorization or a direction to administer. So from a legal perspective, we don't need a wet signature on that. We're quite satisfied across our local health economy that we've got a very robust process in place for an electronic signature, and that's what we've gone for, with the addition of manually populating registration details on the form. And I think that's quite commonplace within acute sectors. The only element of our discharge process that we ask for a wet signature on is our controlled drug smart reports, and that is because we just wanted that extra robustness for that process. But our electronic discharge letters all go through with a digital signature, and actually some of our community partners who dispense medications on our behalf are again very happy with using a digital signature, because they recognise that we've got a strong governance process behind that in our organisation.
And there's a question here saying, so does the prescriber have to prescribe twice? So are they prescribing on the TTO and then the CEDA form, or is it the one thing that covers both? Just thinking about transcribing errors and increasing risk if you've got to do something twice.
Yeah, I think that's a really good point, and I didn't put that slide in the presentation, unfortunately. But with the Sunrise ePMA system, drugs are prescribed for inpatient administration, and then you click to carry them across onto a discharge prescription, and it's almost like a transcribing process, because you don't have to retype. You're simply authorizing the prescribing of those medications at discharge, and then the pharmacist will go in and authorise the dispensing and supply of those medications and do their clinical check. So that it does reduce transcribing errors, because you've got no need to re-prescribe at the point of discharge and no need to re-prescribe for the CEDA form process as well.
And then another interesting question. Do you know when the community nurses are using them, do they print them and use a hard copy, or are they using it electronically as well?
So as part of the discharge process at the Dudley Group, all patients are discharged with a copy of their discharge letter, which includes a copy of all their discharge medications. And because the CEDA form's appended to that, all patients are sent home with a copy of the CEDA form. The community teams have got access to our EPMA system at base. So in the event that the patient hasn't got the authorisation, then the community nurses would be able to access a duplicate copy of that, but that hasn't arisen to date, actually, because our acute team are very sort of versed in making sure that patients are discharged with their discharge letter as part of that process. And then, of course, our GP partners also get a copy of the discharge letter through our EPMA system as well.
And then what about when you've got someone who then has changes in primary care? What do the GPs then do? Do they have access to use the same system, or are they then having to start with the next system?
So unfortunately, the GPs haven't got access to the Acute Trust EPMA system, which is why the paper form was needed. So we've tried to replicate it in as much as we can in terms of the same style and exactly the same clinical information in a format that the community nursing teams are very used to. And I do believe that the GP colleagues can type that, so it's not a handwritten process. But no, unfortunately, they don't have access to the Acute Trust EPMA system because we haven't got that interface in place at the moment at Dudley.
And then I've just got one final question. How did you, or was there any consideration for mis-selection of high strength opiates? Have you got any solutions in to prevent high strength being selected in error?
So one of the things that we have done is probably similar to a lot of organisations that use EPMA systems. So we've got our medicines configured so that controlled drugs are configured with the lowest strength that appears in the drop-down menu first. Obviously, we know that although EPMA systems on a very general level are typically safer than a paper-based system, we know that this is one of the things that's very hard to design out with the digital system in terms of misselection and sound-alike, look-alike drugs. So we have been very conscious of that. And I think having the pharmacist clinical check on there before the CEDA form is sort of released into the community is one of our mitigations to stop that from happening.
That's brilliant. Thank you so much for sharing that with us. There might be a couple more questions, but again, we'll get them sent over to you so you can answer for people where we haven't been able to fit it in now. So thanks again. And I'm going to hand back to Sangeeta. Thank you.
Thank you, Emma. Thank you, Suzanne. That was fantastic. Just a few reflections from me. Today's session, we've been able to look at the use of informatics such as the closed loop experience to help improve patient safety and reduce administration errors with barcode scanning. And we also had Suzanne sharing with us in-house safety solutions, right from planning, implementation, and optimization of processes within the Dudley Group, which was excellent to see to enable the seamless transition of end-of-life care between hospital and community settings. So big thank you to our MSO network, Emma, Cassie, and Suzanne for today's session. I hope all of you have enjoyed it. Just to summarize as well, for our next masterclass, it will be on the 14th of June. And the session will be to evaluate the ePrescribing tool. So the ePrescribing tool is a web-based tool to help NHS hospitals assess and evaluate their ePrescribing systems. So it supports with optimization, it supports with reducing harm caused by adverse drug reactions, and also medication safety. So our next session on the 14th of June will specifically be sharing the findings from the ePRAISE assessment within the systems of various trusts. So we look forward to having you for that session. Once again, thank you very much for joining us today. Emma, I hope you've enjoyed it as well. It's been lovely co-sharing with you. And I wish you all a lovely day, and you get 10 minutes back in your diaries for today. Thank you very much.